We are jumping straight into this kind of microscopic metropolis today, which is operating just beneath the surface of your skin.
Oh yeah, it really is a whole world down there.
Right. And we have a really highly specific, fascinating mission for this deep dive. Like, we are looking at exactly how the presence of free lidocaine, when it's embedded within a dermal filler matrix, how that alters your local tissue sensation during those really critical immediate post-injection hours.
Yes, that immediate window is it's so important.
It really is. So for you listening, we're pulling from a pretty dense stack of sources today. We've got clinical trial data, detailed pharmacokinetic studies, and some really vital safety protocols from cosmetic experts, specifically Dr. Tim Pierce.
Which is great because the intention here is to really map the entire journey of this intervention. We're going to explore the elemental physiology of how a nerve impulse actually works, and then follow that thread to the modern engineering of cosmetic injectables. Because the clinical data shows us that manipulating sensation at the injection site well, it's not just about patient comfort.
Right. It's bigger than that.
Exactly. It fundamentally changes the safety parameters and the practitioner's ability to achieve precise anatomical results. We're looking at not just what happens to your nerves, but why this specific delivery mechanism is such a game changer.
Okay, let's unpack this. Because before we look at how lidocaine operates from inside a gel filler,
Okay.
we really need to define the biological target, right?
Peripheral nerves.
Exactly, the peripheral nerve. My basic understanding is that these nerves are kind of like fiber optic cables carrying signals, but our sources point out they're also incredibly demanding on the body's resources.
Oh, demanding is honestly an understatement. I mean, peripheral nerves are highly metabolically active structures.
Really active, yeah.
Right. If you look at their cross-section, you have these bundles of fascicles, and they're all wrapped in layers of connective tissue. And just to keep those fibers functioning, they require a massive, constant vascular supply.
So lots of blood flow.
A ton of it.
Yeah.
The blood flow required just to keep a peripheral nerve resting, just resting and ready, can be as high as 40 milliliters per 100 grams of tissue every single minute.
Wow. That is a staggering amount of blood just for a sensory wire.
It really is.
And all that metabolic energy is going toward maintaining what the studies call the resting membrane potential. I was reading through the ion distributions, and it's essentially this very stressful balancing act for the cell, right?
It is. The cell is constantly fighting against the natural diffusion of ions.
Mhm.
So at rest, the inside of a nerve cell is heavily loaded with potassium ions,
Okay.
while the outside environment is just packed with sodium ions. And to maintain this artificial imbalance, there's this molecular engine called the sodium-potassium ATPase pump.
That's a mouthful.
Yeah, it is. But it has to continually burn energy, constantly bailing out sodium and pulling in potassium.
Right? I picture it like trying to bail water out of a sinking canoe while also trying to paddle.
That is a perfect analogy, actually.
Thanks. And because of that specific uneven distribution of ions, the nerve cell takes on a negative electrical charge, right? Like a resting potential hovering around -70 to -80 millivolts.
Exactly. It's wound up tight. It's acting like a coiled spring, just waiting for a physical trigger to release that tension.
And the trigger in our context today would be the mechanical puncture of a needle.
Right. When that stimulus occurs, the tension just snaps. Specific voltage-gated sodium channels embedded along that nerve cell membrane, they suddenly swing open.
And then the sodium rushes in.
Exactly. All that sodium concentrated on the outside suddenly rushes in, completely reversing the electrical charge. We call that depolarization.
Depolarization.
And that electrical wave propagates down the axon. And, well, that wave is the physical manifestation of a pain signal heading to your brain.
Which brings us to the lidocaine. Because rather than altering the brain's perception of pain, like, say, an opioid might do, local anesthetics act as a localized physical roadblock, right?
A literal roadblock.
Yeah. Lidocaine molecules wedge themselves into those voltage-gated sodium channels. They just physically plug the pore.
They do. And if the sodium can't rush in, the cell can't depolarize.
So that pain signal simply never forms, regardless of what the needle is doing in the tissue.
Right. But the complexity arises when we look at how those nerve fibers are structured. Because setting up that roadblock isn't always straightforward.
How so?
Well, many of our peripheral nerve fibers are encased in a myelin sheath. It's like a thick layer of lipid insulation. And on these large myelinated axons, signals travel incredibly fast, sometimes up to 100 meters per second.
Because they aren't traveling in a continuous wave, right? They're jumping.
Exactly, they skip.
The signal skips over the myelin insulation and lands on these tiny exposed gaps, the nodes of Ranvier, I think they're called. I like to picture it like a car speeding down a highway, but skipping across a series of small bridges over a river.
I like that.
Yeah, and if you want to stop that speeding car with lidocaine, you can't just block a single bridge. The signal has enough momentum to just jump over a small localized block. Our sources indicate you have to blockade like 3 to 5 of those nodes of intermittent exposure in a row to actually halt the signal.
Yeah, and that structural reality makes blocking deep motor and sensory nerves quite resource intensive. You need a lot of anesthetic.
Right.
However, the specific sensation of sharp, localized pain, along with temperature, that is primarily carried by a different class of nerves called C fibers.
Okay, C fibers.
And these fibers are unmyelinated. They completely lack that lipid insulation.
So they're basically just bare exposed wires in the tissue.
Bare wires.
Yeah.
And they conduct signals at a much slower rate, around just 2 meters per second.
Oh, that's way slower than the 120 meters per second.
Huge difference. And because they lack that myelin sheath, their voltage-gated channels are exposed along the entire length of the axon. So when lidocaine floods the local tissue, it doesn't have to hunt for specific nodes of Ranvier to block.
It can just hit the whole wire.
Exactly. It accesses and shuts down these C fibers almost instantly. They're highly vulnerable to local anesthetics.
That makes perfect sense of the mechanism. Lidocaine finds the uninsulated C fibers and just shuts down the sodium channels. But, looking at the evolution of cosmetic injectables, I kept wondering why go to the massive manufacturing effort of formulating the lidocaine directly into a hyaluronic acid filler.
It's a fair question.
Right. I mean, if the goal is just to bathe the C fibers in anesthetic, couldn't an injector just apply a topical numbing cream beforehand or, I don't know, use a traditional dental nerve block?
You'd think so, but the limitations of topicals and nerve blocks become very apparent when you consider the mechanical precision required for dermal fillers.
Okay, let's talk about topicals first.
Right. So the skin stratum corneum, the outer layer, is a highly effective barrier. A standard clinical topical, like EMLA, which is a mix of 2.5% lidocaine and 2.5% prelocaine, requires significant time to penetrate.
How long are we talking?
Well, to achieve an anesthetic depth of just 3 millimeters, clinical guidelines require leaving the cream on for a full 60 minutes.
An hour just for 3 millimeters?
Yes, and if the injector needs to work at a 4.5 millimeter depth, that wait time extends to 120 minutes. 2 hours.
Waiting 2 hours for the skin to absorb enough cream is just completely impractical for a standard clinical appointment. But what about a nerve block? Like, injecting liquid anesthetics straight into the tissue works instantly for dentists.
It does. But dentists aren't trying to sculpt the tissue they are injecting.
Ah, true.
In cosmetic medicine, a liquid nerve block introduces an unacceptable variable, which is volume.
Oh, because you're adding liquid.
Exactly. When an injector pushes liquid anesthetic into the facial tissue, they are physically expanding that tissue. This artificially distorts the patient's natural anatomy.
I see. So if the cheek or the nasolabial fold is swollen with 2 milliliters of anesthetic fluid, the injector can't accurately assess how much filler is actually needed to correct the wrinkle.
They're essentially flying blind.
It's like trying to paint a portrait on a canvas that is actively bubbling and changing shape. Plus, don't traditional nerve blocks cause a really prolonged numbness?
Oh yeah. They often result in a profound motor block. That classic frozen face effect that lasts for more than 2 hours, which patients absolutely despise.
Nobody wants to leave the clinic drooling.
Exactly. So the clinical demand was for a solution that provided immediate pain relief at the precise location of the needle without adding extra volume or causing hours of paralysis.
Which led to putting it inside the filler itself.
Right. The integration of 0.3% lidocaine directly into the hyaluronic acid, or HA, during the manufacturing process. By adding it as a dry powder, it doesn't dilute the filler concentration or add any mechanical volume that would distort the tissue.
Okay, but I have to push back on the chemistry here, though.
So for it.
Because hyaluronic acid fillers are highly cross-linked, right? They are manufactured to be these robust, dense molecular sponges that resist breaking down in the body. If you trap a dry powder of lidocaine inside a dense cross-linked HA gel, wouldn't that cross-linking trap the drug?
You'd think it would get stuck.
Right. I'd imagine the numbing effect would be severely delayed because the lidocaine is just stuck inside the sponge.
What's fascinating here is that the lidocaine does not interact chemically with the hyaluronic acid at all.
Really, no chemical bonds.
None. They are physically suspended within the matrix, but chemically completely independent. The moment that medical device is extruded from the needle and immersed in the aqueous medium, the natural fluids of human tissue, the lidocaine, is freely and immediately released.
So the body's natural fluids basically just wash the lidocaine right out of the gel instantly.
Yep, the release kinetic is immediate. The filler retains its structural integrity to lift the tissue, while the anesthetic instantly floods the local C fibers.
Since that release happens the second the needle goes in, the timeline of the patient's sensation becomes really interesting because you're awake for this, right? You're experiencing the sensory shifts in real time.
You are, and the data on this is really clear.
Yeah, looking at the Juvederm trials, the drop in procedural pain is stark. Patients logged a 3.4-point drop on an 11-point pain scale when receiving the lidocaine-infused filler versus the raw HA filler.
That's a massive difference for the patient experience.
Totally. Over 93% of subjects found the integrated formulation significantly less painful during the injection itself and during a tissue massaging that happens right after.
And that tissue massaging is often the most physically traumatic part of the procedure.
Oh, I bet.
So having peak anesthesia at that exact moment is critical. But the true elegance of this formulation lies in its very short duration. The anesthetic effect peaks instantly, but it is almost entirely designed to gradually decline and fade during the first hour.
Right, because the lidocaine doesn't just sit there in the face. Once it washes out of the HA matrix, it gets swept up by the local blood vessels and taken straight down to the liver.
The pharmacokinetics here are highly predictable. The liver employs specific enzymes to rapidly dismantle the lidocaine molecule through a process called oxidative N-dealkylation.
Okay, let's break that term down for a second. Oxidative N-dealkylation. The liver enzymes are essentially acting like molecular shears, right? Just clipping carbon branches off the main lidocaine structure.
That is a very accurate way to visualize it. The enzymes cleave specific alkyl groups off the nitrogen atom of the lidocaine molecule.
Okay.
And through this clipping process, the liver converts roughly 64% of the lidocaine into a primary active metabolite called MEDX,
Meliax, got
and
it.
then it continues clipping, converting about 47% of that MEDX into a secondary metabolite called GX.
Wow, it works fast.
It does. And the crucial point here is that the presence of the hyaluronic acid filler in the face does absolutely nothing to alter this pharmacokinetic breakdown. It clears just as fast as if the filler wasn't there.
So what does this all mean? It means the clinical design is remarkably tight. You get rapid onset numbness, perfectly localized to the exact track of the needle,
Exactly.
which allows for a comfortable injection and tissue massage. But because the liver's metabolic shears work so efficiently, that localized numbness vanishes precisely when it's no longer needed. The patient regains normal tissue sensation within about an hour or two, completely bypassing the prolonged frozen face of a dental block.
It's clinically ideal for comfort, yes. And this is a big, but it introduces a profound diagnostic challenge.
The danger window.
Right. We're talking about a 60-minute window where the local tissue sensation is chemically suppressed. Following any cosmetic injection, there is a natural transition from being completely numb to experiencing a mild post-procedural ache as the tissue reacts to the trauma of the needle.
Right. You expect it to throb a little bit as the MAGX and GX clear your system and the C fibers wake back up. But how do a patient or a doctor differentiate that completely normal expected ache from, like, a dangerous complication occurring during that exact same numb window?
This is where Dr. Tim Pierce's safety protocols regarding vascular occlusion become absolutely vital.
Vascular occlusion, or VO.
Yes, a VO occurs when filler material accidentally enters and blocks an artery.
Which is terrifying.
It is, because it immediately cuts off the oxygen supply to the surrounding tissue. If that arterial flow isn't restored quickly, usually by injecting an enzyme called hyaluronidase to dissolve the filler, the tissue will undergo severe necrotic injury. It will die.
And because the area is flooded with lidocaine, the body's primary alarm system, the screaming, agonizing pain from oxygen starvation is temporarily muted.
Exactly.
So Dr. Pierce outlines a specific chronological journey of warning signs that practitioners and patients have to monitor during this altered sensory window. And it starts with the actual moment of injection, right?
Right. The first indicator is disproportionate pain during the procedure.
Okay, disproportionate pain.
Because the integrated lidocaine numbs the tissue as the needle moves, The baseline sensation for all injections should feel relatively mild. If the practitioner moves to a new site and the patient experiences a sudden, sharp, disproportionate spike in pain compared to the rest of the face,
That's a massive red flag.
it is an immediate mechanical indicator that a vessel may have been breached.
So the injector has to be hyper-vigilant of the patient's microexpressions. Like, if they flinch hard on the fifth injection when they were completely relaxed for the first four, you stop immediately.
Exactly, you have to pay attention.
But let's say the injection goes fine, no flinching, and we enter the post-procedure observation phase. The second warning sign is pallor, right? A stark, sudden whitening or paleness of the skin as blood flow stops. But our sources note a major confounding variable here.
The lidocaine itself.
Right. Lidocaine naturally causes local blotchiness and pallor on its own. So how do you tell benign lidocaine pallor from the pallor of a blocked artery?
You need a physical mechanism check, which is the capillary refill test.
How does that work?
The practitioner presses firmly on the pale skin, squeezing out whatever blood remains in the superficial capillaries, and then releases.
And if the blood rushes back and the area pinks up within 2 seconds, the arterial supply is intact, right? It's just the lidocaine acting on the superficial vessel.
Exactly. But if you press the skin, release it, and it stays stark white with zero capillary refill.
Then the artery is structurally blocked.
It is a definitive diagnostic tool.
Mm.
But if the patient leaves the clinic and the occlusion hasn't been caught, the physical signs evolve over the next 15 to 30 minutes as the tissue continues to starve.
And this leads to warning signs 3 and 4.
Right. The skin will often develop something called livido reticularis.
Which looks like a blotchy, net-like, purplish rash. I was reading about this and I was curious why it takes on that specific net-like pattern rather than just turning, uniformly dark or purple.
It's basically a plumbing issue.
Yeah, that's what it sounded like. The blocked artery stops bringing fresh oxygenated blood in, but the venous system is still actively draining blood away from the skin, right?
Right? The venous drainage continues. But without the arterial pressure to push the blood smoothly through the capillary beds, the deoxygenated blood pools in the venules at the periphery of the skin's natural anatomical boundaries.
Ah.
And those boundaries are geometrically arranged, which is why the trapped deoxygenated blood creates that distinct, reticulated, net-like pattern on the surface.
And as that livido reticularis pattern forms, the metabolic clock of the lidocaine is running out. That first hour is ending. This is where the fourth warning sign hits, which is severe, escalating post-procedural throbbing pain.
If we connect this to the bigger picture, this transition phase is where patient education dictates clinical outcomes.
It's so crucial.
Patients expect some discomfort after an injection. They must be explicitly taught the difference between a normal post-procedure ache as the lidocaine wears off and a localized throbbing pain that steadily intensifies as the tissue cries out for oxygen.
Right, because if they assume the severe throbbing is just a normal part of the filler settling, they might just take a painkiller and go to sleep.
And that is the worst-case scenario.
Because by the time they wake up, they've progressed to the fifth warning sign, which is blistering. And these aren't just random blisters, right? They specifically trace the anatomical path of the blocked artery.
Yes. Tissue ischemia rapidly compromises the integrity of the epidermal layers, leading to fluid accumulation and blistering. And Dr. Pierce heavily emphasizes that these ischemic blisters are routinely misdiagnosed.
Really? As what?
Often by urgent care physicians as a herpes simplex outbreak, like a cold sore.
Wow.
But VO blisters follow the path of the artery and tend to present with a more yellowish, pustule-like appearance. It's completely unlike the clustered presentation of a viral outbreak.
It's a pretty sobering reminder that while integrating lidocaine into the HA matrix solved the massive problem of procedural pain, it inadvertently placed this, 60-minute mask over the tissue's natural distress signals.
Which is why the continuous refinement of these formulations is a major focus in cosmetic science. Lidocaine is the current gold standard, but it's not perfect.
No, it's not.
Beyond masking pain, lidocaine exerts a mild vasodilatory effect on its own.
Meaning it opens up the blood vessels.
Right. It naturally relaxes the smooth muscle and blood vessel walls, causing them to open wider.
And opening the vessels means more blood flow, which means the liver sweeps the lidocaine away even faster, right?
Exactly.
So to counteract this and to keep the numbing effect localized for a bit longer, practitioners sometimes compound the filler with epinephrine. Because epinephrine is a potent vasoconstrictor, it clamps those blood vessels down hard, dropping local blood flow to the nerve by an additional 20%.
But clamping the vessels down with epinephrine introduces its own set of significant risks. By aggressively restricting the vascular supply, you increase the risk of nerve ischemia, starving the nerve of oxygen, and you significantly increase the risk of local tissue toxicity.
Because you're trapping the chemical in a confined space. Well, here's where it gets really interesting. What if you don't add more chemicals to counteract the lidocaine? What if you just replace the lidocaine entirely? We reviewed some highly promising studies looking at a newer alternative being studied, which is a different MES-type anesthetic called mepivacaine.
Yes, maybe vaficaine. It shares a structural family with lidocaine, but its behavioral profile in the tissue is distinctly different.
And safer, it sounds like.
Yes. Most notably, mepivacaine demonstrates exceptionally lower vasodilatory activity. In clinical applications, it naturally preserves normal vascular tone or even decreases peripheral blood flow on its own.
So it naturally stays localized in the tissue longer without needing the dangerous addition of epinephrine to force the blood vessels shut. But the other crucial difference the studies highlight is their lipid solubility. This goes back to how easily a drug can cross a cell membrane, right?
Exactly.
Since cell membranes are made of lipid bilayers, basically fat drugs that are highly lipid soluble can slip right through those barriers and enter the systemic bloodstream really quickly.
And that permeability is directly tied to the lipid solubility index. Lidocaine has a lipid solubility index of roughly 1.633.
Okay.
Mepivacaine, on the other hand, sits noticeably lower at 1.322. Because mepivacaine is less lipophilic, meaning it doesn't dissolve into fats as aggressively doing. It doesn't cross cellular membranes with the same reckless speed.
So it's less eager to jump into the bloodstream. It prefers to stay in the interstitial fluid, bathing the C fibers locally, which significantly reduces the risk of systemic toxic reactions.
From a safety and efficacy standpoint, substituting mepivacaine appears highly advantageous. Furthermore, the studies show substituting mepivacaine provides the exact same mechanical filler properties.
The cross-linked sponge stays intact.
Exactly. The HA gel maintains its exact critical strength and stretch rheological scores.
Wow! So just by swapping one localized roadblock for another slightly less lipid-soluble one, the industry could theoretically upgrade the safety of millions of cosmetic procedures worldwide.
It perfectly illustrates the trajectory of aesthetic medicine. You identify a physiological barrier, the rapid firing of voltage-gated sodium channels. You engineer an elegant delivery mechanism, dry powder in a cross-linked matrix, and then you continuously refine the molecular properties to mitigate those secondary risks.
We have covered incredible ground today. We started deep in the physiology of the peripheral nerve, looking at the intense metabolic requirements of maintaining resting potential and how unmyelinated C fibers act as bare wires for pain transmission.
It's quite a journey.
It is. We saw the engineering genius of suspending dry powder lidocaine inside a hyaluronic sponge so it washes out immediately without distorting the face. We tracked the precise 1-hour window where the liver uses oxidative clipping to break lidocaine down into MEGX and GX.
Yeah.
And crucially, we explored the mechanical realities of vascular occlusion from capillary refill to the geometry of levator reticularis and how vital it is to read those warning signs correctly during that sensory transition.
It really forces you to respect the profound complexity of the dermal landscape.
It does.
But before we conclude, consider this final concept. We possess incredibly precise data on how fast lidocaine is metabolized into MEX and GX by the liver, and we know exactly how quickly it clears the local dermal tissue.
Right. The timeline is very predictable.
So what if future injectables went beyond simply delivering anesthesia? Imagine a filler matrix embedded with microscopic biosensors that could map the precise metabolic breakdown of these anesthetics in real time.
Oh, wow.
Imagine an injector looking at a monitor and seeing a dynamic visual pain map of your face, allowing practitioners to dynamically adjust anesthetic formulations on the fly for specific microscopic regions of your skin based entirely on your unique metabolism.
A live metabolic map of your skin responding to interventions in real time. That completely shatters the illusion of the skin as a static, unfeeling wall. It's an active, communicative ecosystem. Well, thank you so much for joining us on this deep dive. Keep questioning the mechanics behind the things you think are simple, and we will catch you next time.